Hello, everyone, and welcome to another episode of Coffee with Clinicians. I'm your host, Cyndi Gillum, here with Dr. David Armstrong. You all know Dr. Armstrong as a wonderful leader in limb salvage and wound care, and probably one of the forefront speakers on those two subject matters. You are a professor of surgery with tenure at the University of Southern California. I know that you work very closely with the School of Medicine there in Keck. Behind you, you've got that logo behind you. So Dr. Armstrong, tell me, how's your day out there in sunny California?
Well, Cyndi, hello, by the way, and I have my coffee now. This is number two. The first one was at about 4:30. This one now. So there we go. Powering up for our chat, Cyndi. It's great. And you see here, it's sunny. It's always sunny in beautiful Southern California. Even, Cyndi, when it's not sunny, it's sunny here in Los Angeles.
That's awesome. It is here in Texas too. We
Are
only
you,
know
are you in
hot
San,
and
are you in
moderate.
San, are you in San Antonio?
I'm halfway between San Antonio and Austin. Yeah.
Well, whereabouts?
In a tiny little dot on the map called Kyle.
Kyle, my gosh, I thought I knew, we lived in San Antonio for a number of years, and God, I must have passed through Kyle on the way to Austin a bunch. Maybe going past Schlitterbahn or whatever that was.
Yes, I lived in New Braunfels for 20 years. I
Oh,
love
New
New
Braunfels.
Braunfels.
Oh, my girls, I used to go on the that lazy river kind of stuff,
Yes.
inner tubes and whatnot when they were very, very little. God bless it. It's good.
Yeah.
That's a pleasure. Now you're going to make me want to go back there some to visit.
Come on back and I'll take you tubing.
My oldest, our oldest, Alexandria, is going to be a third generation foot doctor. So she is going to be rotating, I think in another couple of months with one of my old fellows, Lee Rogers, who's now the chief out at UT Health Science Center in San Antonio. Yeah. And so it's like the third generation, fourth generation, everything is just kind of mixing in. It's so awesome. That is
awesome.
It's a great part of the world.
So because you're such an active leader in the limb salvage community, and I know that you play an active role in speaking out about newest technology and especially wearables, how has this technology really advanced that effort to save limbs and thus save lives? And has it helped with awareness?
Yeah, it's a great question. So there's, I think if you really want to sort of boil this whole thing down, I mean, that making a difference here to sort of maybe be alliterative is marrying kind of team with technology and then adding in some tenacity, right? So those are the three sort of things you have to have. And so the team really supersedes the technology in that regard. We found, and look, you're in San Antonio, we found there at UT Health Science Center that putting, vascular surgeons and podiatric surgeons together can really affect change. Did the same thing in Arizona and Chicago, and of course here in LA and around the world. But that team really is what is most important. What is pretty cool is that there have been some technologies that have helped us in the team to sort of extend how we monitor our patients. And, a lot of the stuff we can do now is we can, instead of doing something to people, we can do stuff with them, and we can dose activity by checking, by checking their activity, and even by checking skin temperature and things like that for signs of inflammation, just like we might have formerly dosed insulin by checking glucose. And that is really, really exciting. So that area has just been taking off, I guess, starting even before I was a student, from the great works of Paul Brand and others. But now to see it happening the way it is, and to become so inexpensive and more ubiquitous with more and more data, is super exciting. So those kinds of things where we can, once we've healed a patient, reduce the risk for recurrence. That's really exciting. That's where it's at. Because, when folks heal these wounds, they're not healed. They're in remission, because just like with cancer, at 40, there's 40% recurrence at 1 year, about 2/3 at 3 years, give or take 3/4 at 5. So I think having that kind of humility and understanding that, while we could do our best to help people and heal people, we really can't heal them. We have to help them maybe move through the world a little better. And hopefully, if they get another wound, when they get another wound, that wound is as short-lived and as minor as possible. We can keep them out of the hospital and keep them super active and happy and productive at home. And I think that's where the team and the technology and a little bit of the tenacity comes into play. Great question.
So with that, I live in Texas and serve a lot of diabetic population. If you could get people to do one thing to improve their foot health, to prevent complications like that from occurring, what would that be? That one thing?
Yeah. Well, just one. Well, okay. Let me say one thing that they can do while they're at the doctor, and then one thing they can do at home. How's that? Am I able to split these apart? Okay.
Absolutely.
So the one thing they could do while they're at their doctors, especially like their general doctor, or if they go and see a nurse practitioner, is look, just knock your socks off, literally or figuratively. If you take your socks off when you are at your doctor, then she or he will be compelled to look at your foot. A primary care doc has so many things to do in the few minutes that she or he has with you, that the foot necessarily is going to get short shrift. So so if you and of course a lot of the things that we're looking for are invisible, or at least they're not perceptible to the patient because they don't have the gift of pain because of their neuropathy. So taking your socks off, that's number one. So that's at the doctor's office. And then number two, if you're at home, you can sort of do the same thing and knock your socks off, and get down there and check your feet every day, just like you comb your hair or you brush your teeth. It's there's not hope for me, but there is hope for a lot of other people with the hair.
That just means you have more time to look at your feet.
I do. My long-suffering, much better half, Tanya, cuts my hair once a week, typically Sunday at 7 p.m. That's our thing. So, but I should have just shaved it. I want to shave it. She just still insists on buzzing it. I don't know, and my dad, first generation toe doctor, he was not vain about anything, by the way. The only thing there was any vanity was he cared about, he had a little hair up here and there was like a comb over.
Yeah.
I know. And he cared so much about, he would use the Pantene and all this other stuff. And I would tell him, why don't you just shave it? And he would just look at me. And anyway, to each his own. So, but back to our patients at home, knock your socks off at home too. And if you can get down there and look at your feet, many of our patients can't, just because they may have, some retinopathy. They may not be able to, be like a yogi and, lift their foot up to their face, but have a member of your family do it. And if you can't do that, there are all kinds of things you can do to help look at your feet. We have our patients, we have a program that we call a foot selfie program, no joke, which is where patients, they can ask for, we send them like a little stand and then they can just put their foot down there and then it's all free. We just do it. And then they can have a photo automatically just taken to the bottom of their feet if they can't get down there, or someone else just takes it. It's all free. And I would say those are things that you could do that could really, really be helpful, because, there's a ulcer, there's a wound that happens in a person with diabetes now around the world every second, give or take. And every, half of those get infected, and 20% of those end up in hospital, which is why there's an amputation every 20 seconds now. And so, many of these things are preventable, and they're preventable with these simple, silly little things. So knock socks off, foot selfie.
I love it. You've been practicing medicine for a while, and so you've seen some things come and go. Oxygen is one of those fun little things that there's still a lot we don't know, I feel like.
Yeah.
How has that evolved for your practice?
We're talking about San Antonio, and when I was fellow training, and then when I was an attending surgeon there at UT, right across the street at Methodist was the alleged birthplace of hyperbaric oxygen. So I had a lot of exposure to that, not only at UT, but, all over that area. And a lot of people were, really active and kind of evangelical about it. And I'll tell you, I, I'll tell you, I was always a little more kind of, I wasn't an evangelist, but I wasn't I wasn't an agnostic either. I was kind of maybe in the middle. And so, or I should say I wasn't a cynic. I was maybe somewhere in the middle. And, but, with topical oxygen, to me, when I first heard about topical oxygen, and this is, in the 90s, I must have done an eye roll, because I said to myself, what the heck is this? Right. I thought, man, this is like quackery for sure. There's just, what are you doing, putting a foot in a bag or whatever this is, and it just didn't make sense to me. And I think I'm on record as saying, I think unless your legs have evolved gills on them, I'm not sure how this is going to work. Because of course it's fundamentally different than if you're inhaling or if you're respiring something, and then you get it, you supersaturate your plasma. But of course, during that same time, there's more and more stuff coming out from various labs. Chandan Sen, my friend formerly from the Ohio State University, and now in IU in Indiana, and a number of others had some really revealing data showing that certainly, number one, the skin does respire. Number two, it very differently, of course, than you would, through your lungs and alveoli. But secondly, you can manipulate the wound environment with oxygen in a way that's very compelling, and that may be pro-angiogenic, that may be anti-inflammatory. And so I started to say, okay, and I became maybe a little less of a, thinking this is quackery, but still thinking, well, the form factor here, it's going to be hard to use this kind of thing. But then as data began to emerge about the use of topical oxygen clinically, I became, more and more pleasantly surprised. And, now, Cyndi, in addition to studies that I've been a part of, by the way, where I would have bet money that the studies that we did would have come out negative or equivocal, because they were really there were sham controlled studies where you had an active unit and a unit where the doctor, the nurse, the patient couldn't tell which was active. And it was really kind of fun because it's kind of elegant way to be able to set up a study. Right. But I was pretty darn well sure there wasn't going to be any signal here. And I was just wrong there. There was. And then now you have, I think, three or four meta-analyses of randomized controlled trials that have been published now that have suggested that this may be helping people. And so I think I'm really happy about that. And it's been something that, we've been trying to incorporate, more and more into our practice. And one of the things that we've seen with it that's pretty compelling has been its effect on pain as well, which we can't really explain right now. We've seen that be really fascinating with people with a lot of tissue loss and using topical oxygen. So there's a lot to explore here, Cyndi. But I've definitely evolved as the data have evolved, I'll say, with this. But I still kind of, but whenever you say it, I still kind of smile because I just think, I imagine, instead of having the nasal cannula here, you have it on the foot, and it just.
Yeah, I was a naysayer too, honestly, until I read the science. And I will say that your perception there is not unrepresentative of what we see with those evangelical HBO guys to go, really, maybe there is something to this,
Right.
and there's room for both.
Yes, Cyndi, these are very different therapies. Yes, oxygen is similar with both of them, but these are very different.
Yeah.
And they're, number one, they're just completely different form factors. One is one where you have to go to it, and several times a week. The other one comes to you and is on essentially 24/7, and is almost like a wound environment. And the two are not mutually exclusive.
Right.
There you have it. Yeah, they're very, very
You're very
different.
different. And you were recently part of a group of doctors who undertook the task of this great meta-analysis that was just recently published in
Yeah.
this week.
Yeah.
And tell me a little bit about your experience and what you and the other authors found with that.
Yeah, it was a great group of characters on there. You could look up the manuscript, but the present company excluded.
Yeah,
It was
exactly.
a bunch of great characters. But this was again, a meta-analysis of the several studies now that have the several RC randomized control trials that have been done, evaluating topical oxygen. And what we found was that there was a significant signal benefiting the use of topical oxygen. We can be sort of device agnostic here. It looks like this being used is beneficial. Now, there may be benefits to one type of a topical oxygen device over another, depending on the scenario and situation, just like there might be benefits to using your phone over your tablet or your laptop, right? And
Right.
so I think that's probably what we're going to be seeing here as these tools become more and more ubiquitous across clinics. And the other good thing about them is that many of these things are not, you don't have to stop one thing to start another, which is really important, because as we start to get more and more good quality companion diagnostics working with these tools, we can start adding other things to the mix that might be synergistic, other categories of therapy, asking ourselves, if this, then this.
So we've talked a lot here about science, but real world is everything to a lot of people. Actually putting your hands on it, touching it, feeling it, play with it. And your team and staff over there at USC Keck is amazing. I would challenge anybody to find a stronger team than what you have over there.
I am the luckiest toe doctor on the planet. For me, I mean, look at me now. I'm on my second or third kind of dressing change. I'm on my second costume change now. I'm just kind of wandering around. It's like like an adult daycare. But boy, I have 8 or 9 elite vascular surgery partners. I have 4 spectacular podiatric surgery partners, are fellows, and then I have plastic surgeons that are world class that we see every day. And then we have our PT wound care, and this was started just before I got there by Rose Ham, and of course Stephanie Wolfel, who's
amazing.
Yeah, Steph.
Yeah.
Good. Dr. Wolfel is a good friend of mine, good friend of ours, and she's in our clinic constantly and is a super important part of it. And she's been the one that's been leading the charge, I think, with using CDO, continuous diffusion of oxygen. I think her experience has been kind of probably what I've told you, has been pleasantly surprised. And again, I think kind of skeptical initially, as was I, because I talked to her about this, about giving this a try, even as we were finishing one of the randomized control trials that hadn't yet shown all the data. So I think, we both had a chance to be kind of skeptical together, and, seeing that this is quite helpful.
And Mark, our CEO, had told us that you had reached out to him about a particular patient that had pain relief that surprised you.
Oh yeah. You're bringing up individual patients. Yeah. Oh, this is a woman that is a security officer and is like a favorite of a lot of people around us, but she is one of those people that you pass almost every day, and she has just this, force of life, joie de vivre and everything. And she developed a wound, and that wound was just sapping the life out of her. It was, it was an inflammatory wound on her leg, and she was kind of getting gorked out on opioids, on gabapentin, on polypharmacy for this life-limiting pain.
Right.
And that was pretty astonishing. Yeah, we did. That's an N=1. So again, your mileage may vary here,
Yeah.
but adding the CDO to this topical oxygen to this patient was transformative and fast, and that totally changed her complexion, and really helped kind of move her on to toward healing. But the healing part wasn't even the important part in this case. The healing, it was the pain part, because
Yeah.
when we she had kind of a massive tissue loss, and she's, thank God, she's in remission now and been doing great. She's working, but if she was, but she went from being completely incapacitated by the pain to very rapidly improving and being able to walk around and function, not just in her house, but around the community. That was really surprising. So there you have it.
And that's why we do what we do. I think why Dr. Wolfold does what she does. And I think those of us who are passionate about wound care and restoring people back to life, science means something, and that's great. But those anecdotal stories mean something too, because we can't ever forget that there's actual patient lives attached to that, and the humanity part sometimes gets lost in all the science. So it makes me feel really good when I get, emails about patients like that, we're making a difference. And it's not always, there is no cookie cutter. It's not one size fits all. It's find what works for that patient and, go with it.
Your mouth to God's ears, Cyndi.
Yeah. Do you feel like Medicare patients would benefit from this technology? And
well, look, I think I don't know how you can tell a Medicare patient with a wound from a non-Medicare patient with a wound. So I would say, look, just follow the data, and yes, sure. There's just that's the biggest problem. So I kind of think with a fragmented, medical system, is that being underinsured or a lack of coverage can be more harmful sometimes than having no insurance. And so and so I think there you have it. So there's your kind of qualified answer, Cyndi, for sure.
And I think that's, all the topical companies next hurdle is just.
And I will tell you, every conversation,
access to care.
Yeah, every conversation that we've had with CMS has been positive one, and has been one that has been about the data. That's so that's the good news. The key is presenting this stuff and getting it forward, and these folks with insurance companies, they have to have the wisdom of Solomon, because it's a zero-sum game, right? And they have to dump one thing to get something else on, and so it's always very, very difficult to put yourself into these folks' shoes, even though you are putting yourself into your patient's shoes every day and struggling with this thing and saying, how can I not get X, Y, or Z for my patient? This is so silly. But there you have it. But yes, this is one of those things for sure.
Yeah, I think it comes back to access to care, and if there's technology, not even just ours, but lots of technology out there that's amazing, that doesn't have coverage as well, and that's hard to swallow when when it works.
Yeah, Cyndi, we just finished having a great meeting in Bethesda. I
saw that.
That was run by Marcia Nesgart, and it's a great meeting. It was the Alliance of Wound Care stakeholders, but it featured leadership from FDA, from CMS, from NIH, right down the block from NIH, and then also from insurance companies as well as clinicians and clinician academics, surgeon academics like me, and it was awesome. I really think that we really broke bread,
That's good.
and you saw that people coming from all these different angles all want to help, and that I think we left there with that, frankly.
Well, I'm going to end on that happy note. So thank you for joining me today and taking time out of your busy schedule to have coffee with me. And I look forward to working with your team more and seeing what other trails you're blazing.
Oh, Cyndi, total pleasure. By the way, do they have oat milk? This is very California. Do they have oat milk in Texas yet?
We do have oat milk, and I laugh because my children, when they were young, called it oak milk. Like it came from an oak tree.
Well, yeah. So this is it could be like a Texas kind of a live oak. So here's to that. Here's to your oak milk and chin chin.
Cheers. Thank you.
Take care, you guys.
All right.